So then moving on from how it's not necessarily transmitting most frequently to how it is transmitting most frequently, you had this really graceful metaphor yesterday on our call. I loved it, about transmission, and please, if you wouldn't mind sharing that with everybody, I think it's super relevant.
All right, I was trying to think of how I could relate it to photography. There's a certain infectious dose that you need to get to acquire the disease. Let's say it's 100 particles. And if you're very close to someone who has a lot of particles, you could get infected very quickly with those 100 particles. If you're very far away in a closed space over a much longer time period, you could also get infected, but it would take longer. If you wanted to do an analogy to a camera, if you think of the aperture, if the aperture is wide open, you're going to be exposed to more photons of light or infectious viral particles, and that'll affect your chance of acquiring the disease. And then the shutter speed is also important because it's the time of exposure. And if the shutter speed, if your aperture is wide open, for example, you'd probably want a very short time period, a short shutter speed, because that would decrease your risk of the virus. And then if you want, you could take that one step further and consider the ISO or ASA, the sensitivity of the film or whatever it is digitally, could predispose certain people with over 65 years of age or people that had underlying illnesses. So, I think photographers are used to playing with those three parameters, and you can think a little bit of your risk of infection, trying to think of whether both people wearing masks, that would be a tight aperture, nobody wearing masks, wide open, length of exposure. Those are all things that photographers usually deal with. So that was my thought anyway.
It's like it goes a step further, because then in both cases you're ending up with an exposure of either the image or to the virus. But basically the sensitivity, your genetic predisposition, sort of this ISO sensitivity. Some people are more predisposed to either get the illness or get very sick from the illness. The length of time that you're exposed to somebody, sort of being the shutter speed analogy, the longer you're exposed, the more likely you are to get it. And the aperture being the amount of exposure you're getting. So because you're really close to somebody who wasn't wearing a mask, that would be like a wide open aperture. But if I'm outside 10 feet away, everyone's wearing a mask, that would be a very small aperture. You would need a lot of time, a lot of exposure in order to get an exposure there.
Correct, exactly.
And I think that really gracefully leads into the idea of ventilation, which we touched on in the first conversation, but I think we didn't realize how important it was. When you started mentioning ventilation, that was the first time I had really thought about it. And now we're discovering that it's even more important. And so maybe we could dive into ventilation a little bit.
Right. Probably one of the primary focuses in keeping anywhere safe is really the ventilation. You want to know how many viral particles are diluted in the air, so to speak. So in hospitals, for rooms where we have somebody who's infected, we usually like to have somewhere between 6 and 12 air exchanges per hour. And they're pulling air out and bringing fresh air in. And that's one of the ways we keep the whole place safe. And we have a little axiom we often say sometimes: dilution is a solution. So your idea, if these particles are coming out, you want to dilute them in as much air as possible, because you'll be exposed to far less the further away you go. And if you're pulling air out of the thing, that's the way to make things a lot safer. In terms, if you don't have an HVAC person to help you with ventilation, there's other simple things. You can open windows, you can use fans, and try to have airflow going right to left or something like that. If you have your talent, and for example, when they're not wearing masks, it would be good if you can to control the airflow, the ventilation going from in one direction, ideally away from people. And if you had open windows or things like that, that would help. So there's a lot of things like that you can do. Face shields are actually controlling the airflow around your face, and they're useful. And on a set, if you wanted to protect certain areas, you could put up plexiglass that basically controls the airflow.
And David, this also leads into ventilation and the the thorny issue of hair and makeup, because obviously at some point the talent has to be unmasked in order for the hair and the makeup to get done. You talked about this on the call yesterday about potentially the hair and makeup person wearing, the advantage of wearing both a mask and a face shield.
Right, correct. It's, the makeup people are working within that 6-foot boundary, and that's when we want to pay particular attention. And really the best way to do it, and there's emerging evidence, there's not a lot of publicity given right now to the face shields, but the mask is good. It will probably eliminate most, over-the-counter surgical masks that you can buy at any store. Will remove about 65 to 85% of the particles, and that'll help you, people that wear them, not transmit it. It'll also protect you the other way. Coming in, we don't have firm data on protection because we usually consider it source control. So the mask protects others in a manner of speaking. The face shield protects you. It protects you from whatever's coming your way. So if you have a mask and a face shield, you have kind of double protection. And when you're working within that 6-foot area, we always recommend that. We actually use that in hospitals. And there are some people that are doing long stints, and some people have gone to sometimes just wearing face shields, which I wouldn't recommend. But there is data that they're almost as protective, as wearing a mask. So it's always good to do both.
And speaking of the cleaning and ventilation and the droplets that are left behind. So if you're on set, what's the time frame of being worried about infection? Like how long, even if you've got ventilation and you're wearing masks, but yet somebody was on set that was asymptomatic and there are particles in the air, how long before you can feel safe that, okay, the particles are gone?
If you have appropriate ventilation, maybe 2 hours, 2 to 3 hours, afterwards. If you have inappropriate ventilation, or you find out afterwards that somebody was infected on the set, you're concerned about it. In general, they recommend, shutting down the area for overnight, or at most 24 hours. And you'll usually see they recommend a deep clean. But once again, we have not seen a lot of transmission from surfaces. Now, there are scientific articles out where they tell you how long it can last on cardboard or metal, steel. And those are in experimental conditions, but still we haven't seen a lot of transmission that way, other than people that are spending a lot of time within that 6-foot range of somebody infected.
Sticking on ventilation for a minute, the question came up several times about HEPA filters.
Right.
Would you describe those a little bit more and explain how those might be helpful?
Right. HEPA filters are high efficiency particulate air filters, and we use them in the hospital as well. We have the 6 to 12 air exchanges, and we also have HEPA filters. And they, when properly maintained, they'll take out about 99% of microbes and viruses and stuff. So that's an added benefit if you can have a HEPA filter. And there are portable machines you can actually set up. So that's good. In airplanes, for example, they use HEPA filters in the air that's recirculated. And airplanes actually have about 20 air exchanges per hour, most commercial flights.
And when you say air exchanges, this was new to me. You're saying bringing fresh air from the outside into the room so that you're not just recirculating the same air. Is that correct?
Well, it's actually taking out air and bringing in new air. And there's different regulations, like for the hospital, for if they have six or 12 air exchanges an hour, there's a requirement that 2 of those exchanges of all the air has to be outside air. So they're not bringing all brand new air, but they're trying to bring in new outside air and keep it circulating. And if you think of the virus, you're kind of diluting you're trying to remove the virus, and you're also diluting it in all this air. So,
but from a simple practical perspective, like on a set, like in our studio, we have a giant fan over there and it points towards a big open door over there. And we open the door behind so that hopefully new air gets sucked in and pushed out towards that way. That's the basic idea?
Yeah, that's terrific. Yeah, that's exactly what you're supposed to do. Now, what you may need to realize, because you don't deal with ventilation all the time, it has to be recirculated and bring in fresh air. Now, if you, like in your car, when it's hot and you just put your air and recirculate, if you have a restaurant or somewhere and you're not removing the air, you're just recirculating the same volume of air, well, then the ventilation really isn't doing much and actually may actually spread the infection. And that's happened in one restaurant in China. So it's important that all ventilation isn't the same. You need to bring in new air and keep the air exchanging with other air.
So for those of us who are dealing with productions on the 5th floor, the 10th floor, and you've got to use freight elevators or passenger elevators, can you speak to being nervous about using an elevator and ventilation?
You know, ideally, if you have an option, if you're going somewhere, it's better to take the stairs than an elevator. The elevator's a closed space, so you would want to limit your time as much as possible in the elevator. Can you be on an elevator with a mask and a face shield and be pretty safe? Yeah. Do you want to do it routinely? Probably not. So.
Okay. Good to know.
One thing that we've seen a lot of right out of the gate as a sort of blunt tool to sort of try to understand who might be sick on a set have been these forms that people are filling out, which, you know, the joke on Instagram is like, do you have COVID? Yes or no? But they sort of try to track, you know, where you've traveled or have you been in contact with anybody, and just sort of self-disclosure. But the other sort of blunt tool has been temperature checks. But we know that a lot of people are asymptomatic and can spread the virus. And I guess I was wondering if you could speak to, my concern would be people having a false sense of security because, oh, everyone had their temperature taken before they got on set, therefore nobody is sick and nobody could be infectious. But that's not true, correct?
That's correct. Currently, the most recent estimates, around 40 to 44% of transmission of this disease is done by asymptomatic individuals. And often people are most infectious just before they develop symptoms. And if you wait for symptoms, you've kind of missed the peak. So just going on temperature, you know, at best you may get, you know, 50% of the people that are infected, but in terms of your set, in terms of safety, if you identify 50%, you're still at very high risk. So what people really want to go towards, and there's technology to do it, is point of care testing. These little paper strip tests that are like the pregnancy test. They're not as sensitive as the PCR and this definitive diagnostic test we use in the hospital, but the test would cost about $1 to $2 a strip. They take about 10 minutes to do. You have an immediate answer, and if you're positive, obviously you go home and call your doctor and do the appropriate things. If you're negative, you know, there's at least probably higher, an 80 to 90% probability you're not capable of transmitting the virus. Does it pick up everyone that's infected? No, but it picks up, you know, 90 and 100% of people that are capable of transmitting the virus. So there's more and more stuff coming out of Harvard and different places that we need these simple tests because you can't rely on the symptoms. The bottom line is you can't rely on the symptoms. So these paper tests are really the way we can kind of open up schools, open up business places, and do it in a very scientific way, you know. And that's hopefully what we'll have if the government will support this soon, because that would make things, that would be a way to open up businesses and schools very easily.
How far away are we from that, David? And there is a question asking, what is this simple test called?
Well, the scientific term, it's a lateral flow assay. So it's a little piece of paper, and they put a little antibody on it, a monoclonal antibody. They put it right on the paper, and then they take saliva or something like that, or secretions, and the secretions go across it. And if the virus is there, it'll bond with the monoclonal antibody, and you'll get a little line, just like a pregnancy test. So it's called a lateral flow assay. They're very cheap, and we could make lots of them, and all of a sudden we wouldn't have to do contact tracing. You know, we talk about getting this test, if you, the diagnostic test, it takes 4 to 9 days. By the time that comes back, the person who's infected is probably no longer infectious, and they're going to go ask him and try to do all his contacts, And that takes hours and hours, and it's almost, undoable. Where this paper strip test, you'd know immediately, and you wouldn't have to do contact tracing. So it's out there, but it was nixed by the FDA because it's not as sensitive as our diagnostic test. But when used appropriately and used repetitively, you'll get the same diagnostic sensitivity.
So
And
a
then-
couple more questions. Yeah, it does. And a couple more questions are coming in about testing, which I know people have a lot of questions about. So first question from Liz Lang is this different than the antigen test? But then I think more generally, just to sort of describe some of the different testing that is out there right now that we're using.
Yeah, this lateral flow assay is an antigen test, The other test, the gold standard test, is called a PCR, or a nucleic acid amplification test. And that picks up RNA from this coronavirus, and it amplifies it to a point where we can detect it. That test has about a sensitivity of 97%. The antigen test depends on the population, but it's somewhere between probably 80 and 90%. And those are the primary tests we're talking about. There's a rapid nucleic acid amplification test called the Abbott Now, and that's the one that the president has, President Trump, that when everyone comes in, they do it, and that nucleic acid test just takes about 10 minutes. So if you had a business and you had to keep it open and you wanted to screen people with something better than a temperature that's a 50-50 shot, you could get this Abbott Now little machine, and you'd get a sample, and you just put it in the machine, and you'd have an answer in about 10 minutes. The other thing you'll hear about is antibody testing, and antibody testing is useful for doctors trying to determine how many people are infected in the country, but it doesn't tell you how many people are immune, so it's not really useful for knowing who's capable of transmitting the virus or not.
So I've been tested a few times now here in Los Angeles, and it's either been a nasal swab administered by somebody else, or a self-administered mouth saliva swab, and then the results would come back 24 hours later. And just because I think those are the most common tests that we've been seeing in LA County, at least, what are the false negative rates on those? If we get tested in 24 hours, we get a negative result. Should we feel somewhat confident, very confident, no confident that we're not infectious with the disease?
It's a very sensitive test. What you're describing is one of the nucleic acid or PCR tests. And it's very sensitive. The main reason for a false negative is that if it's one that goes in the nose or something, if they don't rub it around enough and get enough cells or substance to test it, often it's how the test is obtained if people don't know how to do it. But it's so easy that the self-administered tests now in studies have the same sensitivity as ones administered by healthcare professionals. So it's a good test. Did I answer your question?
Yeah, I guess some Kaiser even said they're having some high false negative rates on those, but they weren't. That was just one nurse practitioner, and she wasn't quite sure where that research had come from. And then I guess the time frame of getting the results back, obviously you could get infected during that time. Maybe is it possible that you get tested before you're highly infectious? Does the time of when you get tested matter in terms of, could you get tested too early after an exposure and then become more infectious later?
Yes, you could. But the tests are extremely accurate for picking up people that are infectious or capable of transmitting the virus. The amount of virus starts off slow and then goes up very steeply and then declines very, very slowly. That's why these people have these positive tests for a long time. One of the problems with the test, in a way, what you're talking about, the test tells you you are not infected when you have the test. It doesn't tell you you won't be infected tomorrow. It doesn't tell you you won't be infected in 2 or 3 days. So therein lies the problem. If you have everyone get a test a week before a shoot and they come in, that tells you they weren't infected a week ago, but it doesn't necessarily tell you they're not infectious 5 days later.
Understood. So moving on to vaccines, and I think some of us for a while have hoped that a vaccine would be a silver bullet, a magic wand at some point that would sort of solve this problem, since we didn't seem to get our federal response wrapped around it in terms of testing and contact tracing like some other countries. But now sounds like there's new conversation about how effective a vaccine might be or might not be. And I wonder if you would burst our bubbles about what we can expect in the springtime if there is success with this Operation Warp Speed vaccine program.
Well, it's really exciting that the money is being put there, and the whole scientific community around the world has come together to make a vaccine. But even if we get a vaccine early next year or later this year, which could happen, I think that's a little optimistic. Before it'll be available, it'll still be some months down the road, and the first people available, there'll be a small batch of at most 100 million doses, and that will probably go to first care responders, people on the front lines. And then there's this huge debate now, who gets it next, whether it's people in nursing homes, whether it's the Black or Latino community that are getting this disease 3 times more frequently than the whites. Who gets the thing? And not everyone agrees on that. So that's a big area of controversy. The other thing, of course, is a lot of these vaccines may not be 100% effective. They may be 50% effective. So that just means 50% of the people will have some immunity. In terms of getting to that famous herd immunity where the whole population's infected, you need over 60%, and we probably won't get there. The other thing we have is with Operation Warp Speed, some of this vaccine stuff has been politicized, which is problematic because we have already vaccine hesitancy, people that are nervous about the vaccine. And if this comes out and it's politicized, people may be nervous about the vaccine, the safety of the vaccine. And for example, if only 50% of the people got the vaccine and it was 50% effective, that means if it works like that, about 25% of the people would have some immunity. And that's not a lot. So before we get a number of vaccines that are effective for the whole population, it's probably, no one knows, but it'll probably be 1 or 2 more years. So it's unrealistic to think, early next year, a vaccine will come out and it'll be available for everyone.
And I'd love to tie that into what we've been talking about, David, because it does burst everyone's bubble because everybody's waiting for the magic bullet. But if what you're saying is correct, all of us should be prepared to have behavior changes for a while, unless we can have this point of care test every day, meaning it's ubiquitous, meaning the only way to know that we're safe is every day we show up and we get tested. So if you could speak to that a little bit, because I think all of us are anxious. We're used to working the way we're used to working, and now we're thinking, oh, we're going to be there soon. So that would be helpful to hear you sort of, all of us need to take a deep breath, and we are going to be working differently for a while.
Yeah, I mean, it's going to be some time before we get back to whatever the new normal is. So it'll be some time. The good news is that we have a lot of evidence that if everyone wears masks and does appropriate social distancing with a little bit of common sense, really works. The areas that have done that, the incidence of this disease has just plummeted. New York City, after being hit very, very bad, really, obviously, they were scared, and they really embraced masking in other places and other cultures, other countries that are used to masks. The incidence of disease has gone way, way down. And when you get a very low incidence of disease, the chance of acquiring disease has all of a sudden become a whole lot lower. So we have a way of controlling it, and we need to kind of embrace that we can control the disease and still work. Lockdowns is a very blunt instrument that obviously will control the disease. But more important, masks, face shields, and some of these other things can also control the disease and allow us to keep our economy open and everyone back at work.
And how many of us have to actually get sick before we, vaccine or no vaccine, and we're all behaving ourselves? how long is it going to take for our planet to have enough people sick so that we can, it's like the flu?
It's not clear. And there are some people, including Tony Fauci, the number one ID doctor, said we may not get there. The idea, will we be able to get to a point of this herd immunity where it's over 60% of people immune, probably more like 70 to 80? Are we going to get there? Probably not. This thing may be around kind of for some time, and the more we're successful with masking and these other things, the longer the disease will be present. So it's not at all clear we'll be able to eliminate this.
And I think that this was, for me, a revelation, because when thinking about the possibility of herd immunity or a vaccine early on in March and April, there was a little bit of an impulse to ride it out and wait for things to get back to normal. But the more there seems to be research around the virus and more information about it, the more it feels like the perspective needs to be that we're going to be living on a spectrum of risk for the foreseeable future, and we need to learn to navigate that risk spectrum in our choices. And we can't just wait it out, but we need to find a way to navigate through this. Do you feel like that's a fair assumption?
No, that's entirely correct. I think the good news is these simple things that sometimes people get tired of and wonder whether it's really useful, they actually work. These masking and social distancing and putting up some of the barriers and ventilation, some of the things we talked about. All those things work, and they can work very well. But in our country, which really emphasizes individual rights, we desperately need to get everyone on the same page with that. And that's been difficult because there hasn't been a lot of national leadership to get everyone on the same page. And clearly, affecting behavioral change like in the young really needs strong, consistent messages from everyone. And we just don't have that. And we have a lot of unfortunate circumstances with large numbers of people getting infected that are related to risky behavior, particularly in the younger population.
And I know we asked this last April, but it's worth asking this question at this point in the conversation. If you have tested positive and you're still walking the planet, you can get it again, but you're not going to die the second time. Meaning, it's
an interesting question. The scientific answer is we don't know that you can get it again. There are some of these viruses, coronaviruses, that you just have immunity for 6 months and then you can get a second infection. There's other ones that you don't get reinfected. So we don't really know that question, whether you can get it again. What the good news is, since the last 5 to 6 months that we've been dealing with this virus, there's been no confirmed case of a reinfection that's been scientifically proven. So that's comforting. So we think probably one infection will confer immunity. We don't know for how long. And the flip side, if you look at vaccines, we don't know how long. If vaccines work, we don't know how long they'll work. And we don't know whether you'll need booster shots or what. So there's a lot of unknown about that.
So after the bad news of vaccines and a lack of federal leadership, there's good news in the sort of therapeutics I've read. Like, we're starting to understand how we could maybe treat the people infected with the virus better. So maybe that risk spectrum would shrink a little bit in the future. Would you speak to that?
Sure. Probably number one, it's really important to realize that over 80% of people that get this virus have mild disease or asymptomatic disease, and over 80% of the people recover and do fine with no long-term consequences. The people that do get sick, we've gotten a whole lot better at treating them using these steroids that you've heard about, dexamethasone, and using this antiviral medicine, remdesivir, early on, and then there's some immune modulating drugs, and then putting them on their tummy. All those have led to improved outcomes. And people in our hospitals in critical care do a phenomenal job. And most of these people are surviving now, where early on, there's a much higher mortality rate. So that's encouraging. We know how to treat this, and there are other things on the horizons, that actually may help us get out of the whole could possibly help us get out of the hole quicker than the whole vaccine issue.
But that, and then the question leads to, why are some states like California and others still struggling? I mean, they had a lockdown and then they opened and now they have to lock down again. It seems like from state to state to state, it varies widely. Like Massachusetts, we've done okay. It's crazy. Because a lot of us in production have to go to different states or, to another country.
It's unsafe behaviors. I mean, what you see on the news, unfortunately, is real. When you see large crowds using the aperture. If you're at a beach with a whole bunch of people, there's a whole bunch of air, but if you're in a whole bunch of people, a whole lot of virus, real close, all afternoon for 5 hours, can you get infected outside at the beach? Sure you can, And you're seeing a lot of risky behavior that's taking place all over the country. You can see just historically, when the southern part of the country reopened early, they paid a big price, and you can look at what happened in some of the southern states in Texas. So it's behavior, and it's unfortunate because that is preventable.
So one thing that strikes me when I think about some of these larger events and large number of people gathering even outside is sometimes it's described and it sounds a little bit like production. We can need to get a large number of people together sometimes, and can sometimes indoors, and have trouble with have logistical challenges around social distancing and all of that. So I guess just to try to tie all of this back to, I'm a photographer, I'm a photo assistant, I'm a hair and makeup artist, I'm a producer, I'm walking on a set. What should I be thinking about as my personal responsibility? And then maybe what should I be looking for from my employer, a producer, the photographer, the client that I'm working for, the set that I'm working on? And what should I be looking out for to keep myself safe and keep others safe?
Well, that's a really big question. I guess number one, everyone has to be safe about themselves. You can't really rely on others, but you have to have a group mentality to try to keep everyone safe. It's the whole thing of the pre-screen, asking the questions. If you have a test, getting a test, washing your hands, wearing a mask. The biggest thing is trying to keep that social distancing. If you have a lot of people, if they can come in at shifts and different things, and if you have talent that's within that 6-foot range, they have to pay particular attention to all the things we've talked about, and the mask and the shield. And then the talent, if they're doing scenes where they're not wearing masks, that's a high-risk situation. You want to control the airflow. You may want to put up plastic barriers between people that are unmasked and other things. And, and then the ventilation, windows open, there's all kinds of things. But once you get the basic concept down, there's a lot of simple things you can do in almost any space.
It does seem like that's so key, that the understanding of the true infection points can really inform your personal safety when you go into these situations that may be more or less risky.
Right. And the other thing, for people that do safety work, if you walk into a setting and you all of a sudden determine it's incredibly unsafe, no matter how everyone planned, because you can have the best plans in the world or the best guidelines, but if you go in and it's a goat rodeo, the best thing you can do is smile and leave, and that's hard, because it's money, that's relationships and all that. But if you feel that it's unsafe based on kind of the things we've talked about, the best thing you can do is walk away.
Thanks for recapping the entire hour in 2 minutes right there. That was well done.
That's amazing.
So we will start adding questions that we see in the chat box as we keep on going. And there was one a few minutes ago from Peter Bowler. What's up, man? About the risk of flying. He asked, given masks and air filtering, it seems safer than is often reported. Any studies of flight attendant infection rate? Just maybe more generally, sure. Where does flying fall on the risk spectrum scale?
Let's use flying as kind of a risk assessment thing, as somebody like I would do. On the good side is they have good ventilation in planes. You heard in hospitals we have 6 to 12 air exchanges. On planes, they have 20 air exchanges an hour, which is very good. That's like we have in operating rooms. That's good. They have HEPA filters, these high efficiency, that's good. And all that sounds really good. That's optimized the ventilation. The bad thing from a technical point of view, the air comes from above, and when we breathe, we have these what we call thermal plumes that go up. So ideally, the air should come from below and up. So that's not perfect, but it's still pretty good. The hard thing is you can't control what other people do. And if there's someone that's infected that's in the seat next to you, or even the seat, not the middle seat, but the other seat, if they're close enough, you're within that 6-foot range, and under circumstances, getting in, getting out, you could acquire the virus very easily if it's very infectious. The other thing is there's always these, fail-safe scenarios. The ventilation in planes aren't good necessarily when they're on the ground, and there have been cases where the planes have had there's one case in 1977 where there was an engine failure somewhere, I think in DC. The plane came down, commercial flight, and it sat on the ground for over 2 hours with the doors closed with no ventilation. Is that good? No, that's kind of a nightmare situation. And so while things are generally safe, depending on what your passengers do and how full the plane is, if a plane is stuck on the ground and the ventilation goes way down on the ground, well, then it's hard to assess the risk. And the hardest thing is what everyone on the plane is going to do that you can't control.
Right. So I guess in terms of risk assessment, there's not just how risky is flying. Obviously, a 2-hour flight with a half-full plane that takes off and lands on time is less risky than a 6-hour flight that is full and you've got an anti-masker sitting next to you with his mask around his chin, drinking coffee, correct, sneezing on you, and you get stuck on the runway for an hour. And I guess it's a fair way to think about sets too, that not all sets are going to be created equal, and we can't say, is it safe to do a photo shoot? Every photo shoot will be on a different place on this risk assessment scale based on the creative we're dealt, the production that we put together, the crew that comes together for it, how much talent interaction there is without masks, how much hair and makeup is required, what the ventilation is, et cetera, et cetera.
Correct. But the other good thing, it sounds like a Boy Scout, but if everyone works together and everyone does their job, it makes a big difference.
So can you speak to what we should do on set or sitting next to some Yahoo on an airplane? What's the best approach to handling people when they're not behaving themselves? I mean, give us some advice other than, calling them a bad name.
It's usually not a good idea to call out people that don't do that. The best thing is to walk away. That's a difficult question. There's people that have been shot and stabbed for those things. Unfortunately, that's happened not infrequently recently, which is really troubling, but you really can't control it. You can ask them nicely, but other than that, you can just try to get up and walk away or find a different seat. But that is one of the big bugaboos that we don't have much control over.
But on set, there are some hierarchies and some power structures that maybe could be used to advantage. Like, if you have a producer who is the person that's going to sign the check at the end of the day, and they're asking someone to put on a mask, it might be different than you just having to needle somebody because you feel
Correct.
unsafe or you think their behavior is unsafe. So maybe we need to leverage those.
Leadership helps. Leadership helps. People at the top. Buying into this really helps. And if someone wanted to have a very, very highly productive place where they're doing all kinds of photo shoots and they want to do it safely, they ought to invest in this Abbott Now thing, one of these little tests that, that you can get results in 10 minutes. And that, and when you have people that you work with develop a sense of safety and security, they work better, there's less risk, and their behavior is better as well, and everyone's happier, and it could be more productive. So doing the right thing from an infection point of view could increase the bottom line.
Yep. So there's a question in the chat while we're on this sort of quick tests you just mentioned again. So, you know, you've mentioned that these tests would be super helpful. The point of care testing, the paper strips, the antigen lateral flow tests, are they available? Can we call a company that does this sort of privately? Or are we just waiting for the federal government to assign those? Well, only, you know, I've heard of people having them on sets, and I've just heard that they're expensive right now. What do you know about?
To my knowledge, none of them have been formally approved by the Food and Drug Administration. And that's where the problem was. And they weren't approved because they weren't, you know, in the 90 to 100% sensitive. And the Food and Drug Administration felt like they got egg on their face early in the epidemic with a test that didn't work very well. So the problem is there's companies that have them that can make them, and they're cheap to make. The government should invest some of the money in them because that would be a far better use of our resources than what we're doing now. But right now, none of them are approved by the FDA. But there's a number of companies that have them, and that you can get them overseas. You can go on maybe online and get one that comes from China, you know. Can't tell you much about the specifics of a test from overseas, though.
Got it. Another question in the chat box. We've heard about podding on set. So obviously we have our sort of quarantine bubbles with our, you know, families, people in our households, maybe our near family past that. On set, especially larger sets with more people over longer periods of time, people have talked about making pods where, you know, you've got your base camp pod with hair and makeup and your talent and some production there, and you have your set pod with some lighting people and props people that need to work together there. I guess the question is, if a person in one pod tested positive, would you need to shut down the entire production, or would a methodology like that provide some layer or level of protection to everybody else?
No, I think it's a good idea. It does provide a layer of protection, and that's what a lot of people are doing. You're forming these small groups, and you realize that they'll all be exposed, and if one person comes down, then everyone needs to be quarantined. And if you can do that on a set and keep people in separate groups, there have been places that have done that and had armbands that are yellow or red or green. It can be useful, but then you need to just be sure how much interaction there is between these different pods. But that's an easy way of thinking of it. You have a large number of people, if you can break them down in smaller numbers, and they're all comfortable saying, well, we're going to work together. We may get sick together, but that's okay, but there'll just be 10 of us, and we'll all watch out for each other. And if they have limited to no interaction with everyone else or controlled interaction, that's a way to decrease the risk, and it's a good idea.
I have one quick question as it relates to risk. We've been talking about masks, and I know in our call yesterday, you said like a three-layer mask.
Oh, right. There's different types of masks, and it's really important. You know, the N95s for the medical field, it works very well at 95%. The next best mask is a 3-ply, you know, surgical mask that you can buy anywhere. It's disposable. It has 3 layers, and it works very well. Up with the same degree of safety, a lot of them, you can make a homemade cotton mask. When you get into felt mask, they can transmit infection worse. That actually makes large particles, small particles, and some of these things that runners wear called gaiters, or these fleece things, they're actually worse. So if you stick to cotton, if you stick to a disposable 3-ply mask, those are the best. So that's a good question because all masks aren't the same. And some people get confused about that.
And then one follow-up, because I know we have a time frame-ish, Matthew, and that is protection for our eyes, David. You know, we have a great mask. Do we need protection for our eyes? And what's the protection rate?
Ideally, within 6 feet, yes. When you're further away, no. And so hair and makeup, yes. And the face shield's the best thing. It wraps around your head. It's not claustrophobic. You can wear that with a mask. And you can feel good because the mask, you're doing something for yourself, but you're really doing a kindness to everyone you work with. And the face shield is giving you protection. And so you've got kind of double protection and your eyes are covered.
Great. Thank you.
So,
Matthew, I think we're good.
Yeah, I mean, I hope that this is helpful for everybody. I know that every time I get the opportunity to speak with you, Dr. Davenport, I feel, it's like the old NBC, the more you know thing. I feel a little star go across my screen, and just feel better the more that we sort of understand even the hard parts and even the complexity. So I thank you for that. I think the last question that I would want to put to you is, you said something yesterday that I think just sort of really illustrates the way the infection's happening, and what some of the preventative measures, how they help. You were talking about a cruise ship early on that didn't have any masks or preventative measures, and not just the number of people that got sick, but how sick they got versus
Right.
a cruise ship later on. I guess just maybe to end on that story.
Sure.
Kind of,
The initial cruise ship that got all the publicity was a Diamond Princess, and a whole lot of people got sick. And when that all happened, no one was wearing masks because no one knew anything about it. They couldn't self-isolate. And the number of people with symptomatic disease and severe disease was very high. Later on, when another ship, and there's a couple of these examples, another ship, someone got infected, everyone was wearing masks and everyone was doing things. And in those circumstances, about 80% of the people that acquired the infection were asymptomatic. And that's really an important thing. And the way that happens is, if you're exposed to a smaller amount of virus, even if you acquire the disease, a smaller amount of virus in most people, you'll have mild or less severe disease. So even if the mask doesn't protect you, if it gives you that degree of protection and you have mild disease, that's already a win. So that's another example that mask and what we're doing actually works.
and that it's not just, did I get the virus or did I not get the virus? It's that how did that
How much you're
infection
exposed
happen?
to may determine how severe the disease is.
Viral load.
Yeah. Oh, and
Right,
overexposure. Your
Yeah.
aperture was too wide, too much light. Your ISO was
Right.
too high. You were overexposed. Well,
Thank
thank
you,
you. Thank you, everybody, for being a part of this. Special thanks to Betsy and Van for introducing us to Dr. Davenport. And of course, a huge thank you to Dr. Davenport for sharing this time with us. It's Zoom, so you don't hear the thunderous applause, but the thunderous applause is happening in all of our hearts and screens over here. But we really, really appreciate it. And
Sure.
you can see in the chat window that people really appreciate this information. And yeah, thank you again.
Right.
And we hope to have follow up when there's more good news.
Yeah.
Yeah. Okay. Yeah.
Yeah, by the way, David, you're a crowd favorite, so you may be with us for a while.
All right. Well,
We appreciate
stay
it.
safe. There's a way we can get through this. That's the important thing. So.
Right on.
right,
Thanks for
thank
the
you, David.
information. Thanks
Thanks,
everyone for being
Matthew.
here. Appreciate
Okay.
everybody. Cheers.
Bye.